question one for Dr. Bard and Dr. Funk is, there are some people that say biopsies open up whatever they're biopsying and spread cancer. Maybe not mainstream medical doctors might not be saying this, but some alternative type people are saying, be careful with a biopsy because you could spread the cancer. So I'd like to get your opinions on that. That's question one. Question two for Dr. Funk, are there some scenarios where you recommend to a healthy woman to remove her breast due to genetics and other risk factors that make you think it makes sense? And question three, for Dr. Campbell, do you have any opinion on whether one, sugar feeds cancer, and then does fruit feed cancer? Because there are some people like Brian Clement at Hippocrates Health Institute that says fruit has sugar, which feeds yeast, mold, fungus, candida, cancer. And he says that Thomas Seyfried from Boston College says this also, or says something that supports this. He doesn't exactly say this. So the question is, does sugar cause cancer? And then does fruit, which most people are saying is wonderful, does fruit itself feed yeast, mold, fungus, candida, cancer, and possibly be a problem because it has sugar in it? So if you could try to repeat the question before you answer it, I'd like to hear from all three of you.
Sure. So does biopsy spread cancer? Let's take a different peek at what we're looking at. First of all, who looks at the biopsy? It's a pathologist. If you're going to give a biopsy, say the size of a golf ball, say under the arm or in the breast, to a pathologist, he is going to look at certain areas, and he cannot find micro metastatic foci unless he's been directed to it. The imaging technology we have been working with now has 2 millimeter detection of cancer foci. So this is one of the things we do. Let's take the sentinel node biopsy that Kristi recommended before. Well, it's very good. In Europe, for example, if you don't see any, if somebody's got a suspicious biopsy, lymph node on the arm, what we do is we image it, first of all, to see if it's abnormal or not abnormal. And secondly, if there is an abnormality, we are able to detect 2 millimeter lymph node metastases now. And we're doing needle biopsies on them and getting cellular material. So frankly, some places are basically, well, okay, let me rewind. Who reads it, how they're doing the biopsy. So the overall thing is you do the imaging on the area as best you can to see what part of the tumor is a true cancer, and then what part of the tumor is inflammatory cellular content going in, what part of the tumor is scar formation within the tumor, and the last part would be immunologic cellular inflammation products in the tumor. So you have really 3 components of a mass, only one of which may be the true aggressive cancer. And again, that's the word. Is it aggressive or not? Kristi said we're finding 2 millimeter tumors in a woman's breast. Why cut something out 2 millimeters? Plus, when you do that, you're leaving a scar, and it's very hard to look at a mammogram after a scar is formed. It's really hard to interpret. And I find that especially true in the skin cancer arena, because almost everybody that comes in referred to me for skin cancer has been biopsied. I come in, when I see patients, I look at their skin, their face, and if it looks like a basal cell on their nose or on their ear, or a squamous cell on their neck, we do the imaging before the biopsy, and then I tell the surgeon what to look for, where to look for it, where it's most accurate. So who is reading the biopsy rather than how are you doing it? That's really critical. We've given this technology at Mount Sinai to the pathology department, how to do microdissection with imaging before you start cutting things up. Also remember that a image especially of a prostate cancer, can look like a horrible cancer, but the tumor cells, as bad as they look, can be physiologically inactive. That's why we do the biologic study. We did the vascular imaging, the blood flow study, or blood flow, the Doppler study with ultrasound, or with all the MRI and let's see, the MRI contrast studies that really show real-time biology as opposed to tumor cells, which may or may not be inactive. So it's a very good question to look at. And from the medical communities I've been to, the internists worry about the cells being spread and the surgeons do not, and the patients really, you got no choice in getting it done to find out what it is. So we need to look at this problem more.
Yeah, so I'll chime in to say there's two issues with biopsies and spread. So the first one is that you have a cancerous mass here, right? You take a needle and you poke it and you're dragging that needle out of the tract. So seeding of the tract with malignant cells, studies show, occurs 1/3 of the time. First of all, 80+% of biopsies are of benign things. So who cares if you seed some benign cells out? In the cancer ones, though, that track, they are pulled out and dragged out. So they're divorced from their blood supply, their angiogenesis, their nutrients. And studies show that if you do a lumpectomy and margins that include that tract, a week after the biopsy, or a month after the biopsy, or 2 months after the biopsy, the quantity of cells that are in that tract and dead goes up and up. So just the passage of time, because the cells didn't come with their little suitcases packed full of all the food they needed, they just die in the tract. For those that don't die, seeding a tract recurrence is exceedingly rare. There was a study out of Australia that looked at exactly that. And they said it happens extremely rarely. Now, if it's cancer, most people, if they accepted the biopsy, are the type of people that are also going to have surgery. So it should just be cut out. And if they have a lumpectomy and there's a little tract cell left behind that just happens to get enough blood supply to live, that person probably was going to have radiation. So you can nuke the tract, or they take tamoxifen, a pill, and then the anti-estrogen effect also makes the cell die. So there's very little concern for a malignant recurrence due to having done a biopsy in the breast. The other concern one might have and should have is, okay, does this biopsy push the cells that were contained in that little walnut of a tumor and push it into the lymphatics, so it went to the lymph nodes, whereas before it wasn't in the nodes, or did it push it right into the bloodstream and off it went? You should start the analysis of that by knowing this. Some studies funded by the NIH back in the 70s showed that if you graft a human breast cancer onto a mouse that's the size of like a 1 centimeter sugar cube worth of cancer, sheds 3.2 million cells into the bloodstream every 24 hours. So you could argue like, nah, what's another 10,000 with my biopsy pushed out? It's like the job of an intact, efficient immune system. And with one pass through the body and the liver and all these foreign body fighting stations in the nodes, these showered cells don't take root and cause metastases in the majority of women, obviously, right? Because otherwise everybody at the moment of breast cancer diagnosis should be metastatic, and they clearly aren't. So the body is doing some cleanup action out there. So the biopsy that might shower some cells in studies doesn't seem to impact overall survival. There was a study looking at, this was an Austrian review of 1,890 patients. They had breast cancer, underwent surgery, and then they had a sentinel node biopsy, which is where you take out, everybody varies, like 30 to 50 nodes in the armpit. Really, unless it's obvious there's tumor in them. We just care about the 1 or 2 that first get that lymph drainage from the breast. It's like the guard of the armpit, and it's why it's called sentinel. So this sentinel node biopsy, they concluded that a preoperative biopsy, a core biopsy stabbing the tumor, does not cause artificial spread to the nodes, but there are other studies that show the opposite, that in fact biopsy does cause transport of cells. Again, their ultimate conclusion is that the cell's behavior in that node doesn't impact survival. And it might be because of what I explained before, like they're pushed there. They didn't actually travel and metastasize there with all the things they needed intact to then create a bigger problem. And then finally, I'd just like to point out the logistics. I mean, if we are able to evolve with Dr. Bard's studied technologies where imaging can give you a benign or malignant yes or no, then what I'm about to say is irrelevant. But if you, every time you have a mass, remember 80+% of biopsies are benign, and therefore you get to avoid going to an operating room, having an incision, anesthesia, a scar, maybe a cosmetic, like it goes on. And with the downsides of doing an open biopsy, there was a study in 2008 in Florida that they had a really high open biopsy rate of 30%, which is very high because we usually do these cores. And that led, in just 1 year in that one state, it led to $112 million in payments for these open biopsies that we generally do by these, core biopsies. And if you extrapolate that data to the millions of biopsies done in the world, you're talking about trillions of dollars, and that's just the money part. So I'm pro biopsy.
Thank you. Also, I had asked about breast removal. Is there ever a case when you do that?
Oh, definitely. So prophylactic mastectomy, it's very individualized to the story a given woman is living. So if you have, say, a BRCA1 gene mutation, your personal risk of breast cancer, depending on your current age, like if you're 30 years old, your lifetime risk of breast cancer can approach 87%. And that threat and the fact that 87 can become essentially zero with prophylactic mastectomy warrants a conversation about that. There are other gene mutations where the risk of cancer is not so astoundingly high, and we might just choose higher risk surveillance. So instead of like a mammo a year and you're done, you see me twice a year for a hands-on exam. We do screening ultrasounds and mammogram and an MRI. Speaking to Dr. Bard's gadolinium pooling in the brain concern, I have a very deep concern about that, and really space the MRIs out to be usually every 2 to 3 years, depending on the risk level. But for sure, prophylactic, meaning no cancer is known to be in the breast. Prophylactic mastectomy is a discussion and a thing I do often because there are a lot of high-risk situations out there that lead women to a more confident life. Like they're like, you know what, I hear all these stats and I know surveillance is an option, but I don't want to show up. I don't want to show up for the mammogram and the ultrasound and a biopsy every time there's a blip on the radar because I'm higher risk. Like I just want to have total peace of mind. I feel like, I'm just waiting for the shoe to drop. Oh, now I have invasive cancer. See, I should have done the prophylactic mastectomy.
Is breast cancer a concern for women who have very small breasts or almost no breasts? Is it less risk?
That's another myth. It's in the myths. So small-breasted women indeed have the exact same risk of breast cancer as larger breasted women. By and large, large breasts have a lot of fat and stroma and things that don't actually make breast cancer. So thinner women have denser breast tissue, and as Dr. Bard accurately mentioned, they have a higher risk of breast cancer simply due to that density. It's because what makes a breast dense is the stuff that makes the cancer, the milk producing lobules and the tiny little ducts. So no, I know they feel like doubly unlucky if they were wanting bigger breasts. They're like, I am flat chested and I don't get a reduction in breast cancer risk. No, you don't.
Are you saying they have a higher risk?
So if they are small breasted and very dense, so we grade density A through D. Only 10% of women are D, and only 10% of women are A. So the vast majority, 80%, are in the middle range of B and C. So when you compare the D, densest people, to the A's, the fattiest people, then you have 4 to 6 times the elevation in risk. So like a 300 to 500% increase in risk. But it's just the densest compared to the fattiest. Most women are in the middle, so it's not all dense women, because the C level women is like 40% of people.
So
But they can have a higher risk. Now, to offset that, your tiny breasted women tend to be ideal body weight. So they're in a normal body mass index. They tend to be more athletic. So they offset some of the increased risk by the density by having a healthier lifestyle.
sorry for not listening carefully, but so you want ideally low density or high density breasts, which is better for cancer prevention?
Low density.
So you want low density.
Yep.
And could any woman find this out by going to her doctor?
No, technically the only way to know if you're dense breasted or not would be the visual interpretation of a mammogram on how much like white splotchy stuff there is, because density appears white and fat appears black. But with enough experience, right, Dr. Bard, like I can tell density on an ultrasound, but the rule is it's read by a mammogram.
Well, let me respond to that, because I'm also medical advisor to the Are You Dense Foundation. And I've been disturbed by the fact that mammograms, depending upon the compression and the X-ray strength, can show wildly different amounts of density. So we've developed a 3D ultrasound technology that quantifies the breast density. So this deserves further discussion, because I agree with you that you have to have a general overview marker of visual. There's got to be a better way of quantifying breast density, because you're giving advice to women on their risk based on it. So maybe we can find, if not ultrasound, maybe there'll be another technology like spectral imaging of breast tissue or sonic imaging. There are a lot of new technologies that are going through the breast now. Be interesting opportunity.
Thank you.
For something totally different, does sugar feed cancer? So the question was, does sugar feed cancer? And then the secondary follow-up is, does fruit cause cancer? And I don't like the idea of sugar feeding cancer as a popular idea. And the reason is that your whole dietary pattern matters a lot more than just saying sugar feeds cancer, because if you think that it's just sugar feeding cancer, you might skip the chocolate bar, which is great, fine, but then have the McDonald's burger. And this idea that cancer cells gobble up more sugar than other normal cells, okay, fine, but nutrition, the food you eat and the nutrients in your body and how they get there and how they interact, there is a lot of steps in there, and there is a lot of interactions between different nutrients that happen. And we know cancer cells respond not just to sugar and the fuel, but they respond to hormones. They respond to sex hormones. They respond to growth factors like IGF-1. They respond to insulin and insulin, whether you're sensitive to insulin sensitivity, just like your normal cells do. And we know that when these metabolic problems happen, that can also affect risk for cancer. So the idea that it's just sugar feeding cancer is way too simplistic. I'm not a fan of a lot of sugar in a diet, but I think people really need to focus on the whole dietary pattern and focus more on whole food, plant-based, rather than thinking it's just sugar is sort of the magical evil thing. I think that's way too simplistic. And does fruit cause cancer? I will just respond kind of with a simply saying I don't think so. No, I would disagree in saying that fruit causes cancer.